Essentials of Pharmacology for Health Professions, Ninth Edition, Chapter 23, Endocrine System Drugs. Chapter Objectives. Upon completion of this chapter, the learner should be able to identify the hormones secreted by these four endocrine glands: pituitary, adrenals, thyroid, and pancreas. Describe the various conditions that can be treated with corticosteroids. Explain the proper administration of corticosteroid therapy. List serious potential side effects of long-term steroid therapy. Describe medications given for hypothyroidism and hyperthyroidism and their side effects. Identify the symptoms of hypoglycemia and hyperglycemia and appropriate interventions. Explain the uses and side effects of oral and injectable non-insulin antidiabetics, and compare and contrast insulins according to their action: rapid, intermediate, and long-acting, naming the onset, peak, and duration of each category. The endocrine system. Like the nervous system, the endocrine system can be thought of as a body control system. The endocrine system consists of glands that secrete hormones and other substances responsible for function of the body's cells and organs. There are four categories in the hormones that they produce, and we'll talk about those in this chapter. They include the pituitary, which includes somatotropin and adrenocorticotropic hormones, the adrenals or corticosteroids, thyroid, thyroxine T4 and triiodothyronin T3, and pancreas, which we talk about with the insulin. Let's first talk about what endocrine means and break it down. Endo means within, and endocrine is referring to the internal secretion of hormones that are produced by a ductless gland that secretes directly into the bloodstream. The hormones are chemical messengers that have specialized functions in regulating the activities of specific cells or organs as they travel through the bloodstream to their targets. The endocrine system drugs, these include natural hormone drugs, and these are secreted by the ductless glands directly into the bloodstream. There's four categories in this chapter that we will discuss, and they include the pituitary hormones, adrenal hormones, thyroid agents, and anti-diabetic agents. There's also synthetic hormone drugs, and these are lab created, meaning that they're artificial, they're made in a lab, and they're used to treat hormonal imbalances. The first of the hormones is the pituitary hormones. The pituitary gland is known as the master gland, and that's because it has important functions in controlling body systems. The hormones secreted from the pituitary include somatotropin, adrenocorticotropic hormone or ACTH, thyroid stimulating hormone or TSH, and gonadotropic hormones, FSH, LH, and LTH, which we'll discuss further in the chapter. As you can see in this picture, the pituitary gland hormones and what their function is with each system: the ovaries, the testes, bones, tissues, skin, mammary glands, adrenal cortex, thyroid gland, mammary glands, uterus, smooth muscle, and the kidney. Now let's check activity 23.1. Which hormone is secreted by the kidneys? A. Prolactin, B. Oxytocin, C. Erythropoietin, or D. ACTH. Write your answer down and then you can check it at the end of the PowerPoint. The adrenal glands, which are located next to the kidneys, secrete the hormones called corticosteroids. These act on the immune system to suppress the body's response to infection or trauma. They relieve inflammation, reduce swelling, and suppress symptoms in acute conditions. They can also be subdivided into two broad categories. They're used as replacement therapy when secretions of the pituitary or adrenal glands are deficient, and as anti-inflammatory and immunosuppressant agents. Now their purpose is just to support, they're not to cure. And there's some conditions that we use these corticosteroids with to treat, and I'll talk about those on the next slide. As I mentioned previously, the conditions treated with the corticosteroids include allergic reactions, such as insect bites, poison plants, chemicals, other medications. Acute flare-ups of rheumatic or collagen disorders, especially where there's only a few inflamed joints, and that can be injected with those corticosteroids. Acute flare-ups of severe skin conditions that do not respond to any other conservative therapy. Acute respiratory disorders such as status asthmaticus. Long-term prevention of symptoms in severe persistent asthma or chronic management of COPD. Malignancies such as leukemia, lymphoma, Hodgkin's disease, in which the corticosteroids or prednisone, and they're used with other anti-neoplastic drugs as part of chemo regimens. Cerebral edema, this is associated with brain tumor or neurosurgery. Organ transplant, now these are those corticosteroids, they're used with other immunosuppressive drugs to prevent the rejection of transplanted organs. They're also used for life-threatening shock in acute flare-ups of ulcerative colitis. They're only used for this condition in short term to avoid hemorrhage. Knowledge check activity 23.2. Which is not a condition that can be treated by adrenal corticosteroids? A. Malignancies. B. Ulcerative colitis. C. Hypertension. Or D. Respiratory disorders. Write your answer down and you can check it at the end of the PowerPoint. Prolonged administration of corticosteroids can cause suppression of the pituitary gland with adrenocortical atrophy, in which the body will no longer produce its own hormones. And due to the potentially serious side effects, corticosteroids, they're only administered for a short time as possible and locally if possible to reduce any systemic effects. To administer this can be done through ointments, intra-articular injections, ophthalmic drops, and respiratory aerosol inhalants. There are some very serious side effects that can occur with corticosteroid use, and that's why they are only administered for a short term as possible and locally if possible to reduce any systemic effects. The following list the side effects of the corticosteroids, the adrenal corticosteroids, the contraindications, and the drug-drug interactions. Knowledge check activity 23.3. Which route or routes of administration can be used for corticosteroid therapy? Mark all that apply. A. Oral or PO. B. Intravenous or IV. C. Intramuscular or IM. Or D. Nasogastric tube or NG. Choose the best answer or all that apply. Write them down and then you can check them at the end of the PowerPoint. Knowledge check activity 23.4. Which health conditions are not a long-term effects associated with a systemic steroid therapy? Mark all that apply. A. Osteoporosis. B. Hyperlipidemia. C. Adrenocortical atrophy. Or D. Stunning of growth in children. Choose all that apply. Write your answer down and you can check at the end of the PowerPoint. The thyroid gland is an endocrine gland located in the front part of the neck. It's responsible for regulating the rate of metabolism. When the thyroid levels are low, the pituitary gland releases TSH, or thyroid stimulating hormone. TSH promotes the biosynthesis and secretion of two bioactive hormones, which are thyroxine T4 or triiodothyronin T3. The thyroid agents used can be natural thyroid or synthetic, such as Synthroid. The most common disorder affecting the thyroid gland is hypothyroidism, which is low thyroidism, and it's caused by diminished or absent thyroid function. As you can see in the picture, the symptoms of hypothyroidism: thinning hair or hair loss, loss of eyebrow hair, puffy face, enlarged thyroid. Patients may have dry and coarse skin, slow heartbeat, poor appetite, constipation, infertility or heavy menstruation, carpal tunnel syndrome, cool extremities, and swelling of the limbs. Weight gain, poor memory, intolerance to cold, and feeling of tiredness. The hypothyroid conditions that require replacement therapy include cretinism, which is a congenital problem. It requires immediate treatment to prevent intellectual disabilities. Myxedema or adult hypothyroidism. This is owing to simple goiter. Hashimoto's thyroiditis. Pituitary disorders, medications, and thyroid destruction from surgery or radiation. Hypothyroidism causes slowed metabolism, symptoms ranging from fatigue, somnolence, dry skin, thinning hair, weight gain, constipation, sensitivity to cold, and irregular menses to mental deterioration, including depression if untreated. There is a transient hypothyroidism, which is a rare problem, and thyroid replacement therapy for true hypothyroidism must be continued for life. Levothyroxine or Synthroid, this is a replacement therapy that is used. The initial dose would be 100 to 125 micrograms, and then it would need to be adjusted based on the symptoms, TSH level, and body composition. TSH levels are drawn every 4 to 6 weeks until the dosage is stabilized. An overdosage of thyroid hormones can cause toxic effects, and these are manifested in the signs of hyperthyroidism. You can see the toxic effects of levothyroxine or Synthroid listed here, the conditions and cautions, and drug-drug and drug-food interactions. Please note the side effects, which would be toxic, as I explained, and are manifested for signs of hyperthyroidism. Hyperthyroidism can be caused by Graves' disease, which is an autoimmune disorder where antibodies mistakenly attack the thyroid gland, and also thyroiditis, which is inflammation of the thyroid gland. Orally administered radioactive iodine ablation or destruction therapy is the most common treatment for Graves' disease, and most patients are cured after a single dose. Surgery to remove all or part of the diseased thyroid is another permanent cure for hyperthyroidism, but seldom used. Now, the cure for hyperthyroidism is the destruction or removal of the gland, resulting in hypothyroidism. This results in most people with hyperthyroidism needing lifelong hypothyroid treatment. If you see in the picture to the right, the Graves' disease symptoms: exophthalmos, which is bulging eyes, sweating, goiter, enlarged gland there in the throat, arrhythmia and tachycardia, nausea, diarrhea, oligomenorrhea in females, muscle weakness, and tremors. It can also include headaches, weight loss, nervousness, and emotional instability. The agents used for hyperthyroidism are your antithyroid agents, such as tapazole or PTU. These are used to relieve the symptoms of hyperthyroidism in preparation for surgical or radioactive iodine therapy, or for those patients who are not candidates for either procedure. Keep in mind that the antithyroid drugs are not helpful for the treatment of hyperthyroidism associated with thyroiditis, because this condition is due to the release, not the overproduction of thyroid hormones. Side effects and cautions of the antithyroid agents are included here. They include rash, urticaria, pruritus. You want to treat with antihistamines for this. Abnormal sense of taste, blood dyscrasias, especially agranulocytosis. And cautions include prolonged therapy, which is seldom used, patients older than 40, pregnancy, lactation, hepatic disorders, which there's a black box warning with the PTU. And there are a few drug-drug interactions, and those include other drugs causing agranulocytosis. They are potentiated, and excessive iodine intake, or drugs containing iodine, such as amiodarone, which will cause decreased efficacy. Knowledge check activity 23.5. A patient with Hashimoto's thyroiditis is prescribed levothyroxine or Synthroid. Which signs or symptoms indicate drug toxicity? Mark all that apply. A. Tachycardia. B. Hypoglycemia. C. Weight gain. Or D. Excessive sweating. Choose all that apply. Write your answer down and you can check them at the end of the PowerPoint. Diabetes mellitus, or DM, makes up a group of hormonal diseases characterized by impaired metabolism of carbohydrates, fats, and proteins that results in elevated levels of blood glucose. DM is classified as type 1 or type 2. Type 1 results from generic or clinical destruction of pancreatic beta cells. Type 2 results from a loss of sensitivity to insulin, which results from genetics or lifestyle, to include diet, exercise, etc., or a combination of the two. Long-term, poorly controlled diabetes can result in vascular injury, which is categorized as microvascular or macrovascular. Common complications of each include microvascular, retinopathy, nephropathy, and neuropathy. Macrovascular includes coronary artery disease, including myocardial infarction, cerebrovascular disease, including stroke, and peripheral vascular disease. DM is considered to be the 7th leading cause of death in the United States. About 70% of patients die of heart disease or stroke. Medications administered to lower blood glucose levels include parenteral insulin and oral and injectable non-insulin anti-diabetic agents. Insulin is required as replacement therapy for patients with type 1 diabetes with insufficient production of insulin from the islets of Langerhans in the pancreas. It's also required with type 2 diabetes who have failed to maintain satisfactory concentrations of blood glucose with therapy including dietary regulation and oral anti-diabetic agents. Insulin must be administered parenterally because it is destroyed in the GI tract. There are newer inhaled insulin preparations currently being researched but not used regularly in practice yet. Most insulin used today is U100, which means that there are 100 units of insulin in each milliliter. The insulin syringe must be marked U100 to match the insulin used. There are several types of insulins out there, and we will discuss those in a chart in the next couple of slides. This slide shows the diabetes classifications, the difference between type 1 and type 2. Characteristics, you're looking at age. Usually type 1 is young, usually less than 35 years old. Type 2 are older patients. Onset, type 1 is rapid. You see ketoacidosis. And type 2 is gradual with no symptoms in early stages. Body composition with type 1, it's non-obese. And type 2, they're obese. Cause, type 1, body cannot produce insulin. In type 2, insulin production is normal or altered to some degree. Body cells are resistant to the insulin. Management, type 1, insulin injections with diet and exercise. Type 2, oral, injectable, and non-insulin medications with insulin injections only if needed, and also diet and exercise. This slide shows the comparisons and contrasts with the different insulins that are used. Note rapid and short. These are sometimes combined also. There are several of these. Rapid or short acting, as we know, sometimes ordered as corrective dose. You see the onset for rapid is 10 to 30 minutes. The peak is 1 to 2 hours, and it lasts 3 to 6 hours. Trade name is Novolog and Humalog. There's some different ones there. The short acting is preparation is regular. Trade name is Humulin R. Onset's 30 to 60 minutes with a peak of 1 to 5 hours, and it lasts for 6 to 10 hours. There's also Novolin R. And then you have some others listed there. Knowledge check activity 23-6. Which insulin preparation has no peak with a duration of up to 24 hours depending on the dose prescribed? A. Novolog 7030, B. Aspart or Novolog, C. Glargine or Lantus, or D. Isophane NPH or Humulin N. Choose your answer, write it down, and you can check it at the end of the PowerPoint. Now we will discuss some conditions that can occur with diabetes. The first is hyperglycemia, or high blood glucose. This can result from a few of these are undiagnosed diabetes, infections, emotional stress, medications such as prednisone, pregnancy, surgery or other trauma. And some signs and symptoms that we want to look at with hyperglycemia is dehydration, anorexia, unexplained weight loss in persons under 40 years of age, polyuria, which is frequent urination, fruity breath, lethargy, weakness, flu symptoms, and coma if untreated, vision problems, and ketoacidosis, which is urine acetone. Treatment for hyperglycemia include IV fluids, regular insulin, and correct electrolyte imbalances. There are a few interactions. And then the second condition is hypoglycemia, which is lowered blood glucose. This can result from an overdose of insulin or other anti-diabetic medications, delayed or insufficient food intake if someone is dieting, maybe too much exercise, change in the type of insulin from analog to human insulin, for example. And signs and symptoms include increased perspiration, pallor, hunger, nausea and vomiting, irritability, confusion, or sudden unexplained bizarre moodiness or behavior, tremors, weakness, headache, hypothermia or tingling of the fingers, blurred or double vision, tachycardia and shallow breathing, loss of consciousness and convulsions if untreated, and hypoglycemic reactions in older diabetics may mimic a stroke. Treatment for hypoglycemia include administer orange juice, honey, or other foods to bring up the blood glucose, followed by a protein snack. If they are comatose, you want to administer 50% dextrose or glucagon. Knowledge check activity 23-7. Which are signs or symptoms of hyperglycemia? Mark all that apply. A. Dehydration, B. Fruity breath, C. Shallow breathing, or D. Sudden moodiness. Choose all that apply, write your answers down, and check it at the end of the video. This slide lists the oral hypoglycemic agents and injectable non-insulin agents. These will be discussed in further detail on the next two slides. Please note the figure 23.5. This shows common sites for insulin injections. Sites need to be rotated and the site recorded each time on the medication record. Now we will discuss the oral and injectable non-insulin anti-diabetic agents. Type 2 diabetes results from insulin resistance, insulin produced but not used effectively by the cells, combined with relative insulin deficiency. It's often necessary to combine diet and oral anti-diabetic agents. These medications are not a substitute for dietary management. The first one is the biguanides or metformin. They work by decreasing hepatic glucose production and enhancing insulin uptake in muscle tissue. They can be used in combination with sulfonylureas, alpha-glucosidase inhibitors, or insulin to treat type 2 diabetes or prediabetes. They are the preferred initial first-line monotherapy. Side effects, there are some listed there: GI effects, diarrhea, nausea, vomiting, bloating, flatulence, metallic taste, anorexia, and weight loss, which usually these are mild. They can resolve during treatment, and they can take the medication with food to minimize epigastric discomfort. The next one is sulfonylureas. and those are the two there. They work by increasing insulin production from the pancreas and by improving peripheral insulin activity. Side effects with these: GI distress, may subside with dosage regulation. Dermatological effects, including pruritus, rash, urticaria, or photosensitivity. Hypoglycemia, especially in older adults. They must eat consistently while on these sulfonylureas. Weight gain and water retention. The next is alpha glucosidase inhibitors, acarbose. They delay digestion of complex carbohydrates such as your starches and subsequent absorption of glucose, and this results in a smaller rise in the blood glucose concentrations following meals. They can be used as monotherapy or part of a combination regimen that includes insulin, metformin, or an oral sulfonylurea. Side effects with these include high rate of GI effects, flatulence, abdominal distension or pain, and loose stools. And this tends to diminish with time or a reduction in dose. Take at the start with the first bite of main meals. And elevated liver enzymes, which is dose related, generally is asymptomatic and reversible. This slide shows other oral and injectable non-insulin anti-diabetic agents for type 2. The first one is incretin therapies, such as exenatide. This is an adjuvant therapy for type 2 patients who have not achieved glycemic control and are taking metformin, a sulfonylurea, or a glitazone. They decrease glucagon secretion, delay gastric emptying time, and decrease food intake, which increases satiety, resulting in weight loss. Side effects are nausea, vomiting, diarrhea, dyspepsia, gastroesophageal reflux, injection site reactions, and hypoglycemia. The next agent is the meglitinides, such as Starlex or Prandin. These stimulate the beta cells of the pancreas to produce insulin. They can be used as monotherapy or in combination with metformin. Side effects with these include GI effects, nausea or vomiting, diarrhea, constipation, dyspepsia, and abdominal cramps. Hypoglycemia, initial weight gain. Upper respiratory infection, sinusitis, arthralgia, and headache. The next agents are your thiazide, linodiones, Actose, or Avandia. These lower blood glucose by decreasing insulin resistance and improving sensitivity to insulin in muscle, liver, and adipose tissue. They can also be used as monotherapy or concomitantly with other agents. Several side effects: weight gain, fluid retention, and edema, URI, sinusitis, pharyngitis, and headache. Myalgia, atypical bone fractures, which would be the upper arm, hand, and foot. Anemia, hypoglycemia in combination with insulin or oral hypoglycemics. And the last anti-diabetic agent is your sodium glucose cotransporter 2, or SGLT2 inhibitors. Invanca, Jardiance, and Farxiga. They work by decreasing the reabsorption of glucose in the kidneys, essentially lowering glucose available to the body via excretion. They can be used as monotherapy or in combination with oral medications. Side effects of these include vaginal yeast infection, urinary tract infections, and increased desire to urinate. Please keep in mind to read your patient education for patients who take type 1 or who are type 1 and type 2 diabetics. Definitely want to rotate injection sites, and also provides information about prevention of hypoglycemia, low blood sugar, substituting foods with glycemic index, regular exercise, good foot care, taking your medications the same time each day, using your monitoring devices properly, and maintaining aseptic technique, definitely with injections. And as I said, rotating the sites is important, and you want to record that in the medication record each time. Case study. A diabetic patient presents to the emergency room. The spouse stated that the patient was fine when they first got up. The patient took their insulin, had a shower, and then had a cup of coffee. About 2 hours later, the patient began to experience blurred vision, tremors, nausea, difficulty speaking, stumbling around, and slurred speech. After initial testing and evaluation, the physician diagnosed the patient as having a blank episode. Was it hypothyroidism, hypoglycemic, hyperglycemic, or hypertension? Choose the best answer for this case study, write it down, and you can check the answer on the next slide. If you chose answer B, hypoglycemic, that is correct. For this case study, the patient was experiencing low blood sugar. Knowledge check activity 23.8. Which drug is the preferred initial first-line monotherapy for DM? That is A, acarbose, B, glyburide, C, glimepiride, or D, metformin. Choose the best answer, write it down, and you can check at the end of the video. Now you can check your answers to see if you answered the knowledge check activities correct. This slide contains activity answers for 23.1 through 4. Check to see if you answered correctly for the knowledge check activities for 23.5 through 8. Now you can assess yourself to see what you've learned from this video in this chapter. Answer the following questions, write your answers down, and then review the video if you need to check your answers. Number 1, what is the pituitary gland also known as? Number 2, what are the signs and symptoms of hypoglycemia? And number 3, what are the onset times of rapid, intermediate, and long-acting insulin? This concludes Chapter 23, Endocrine System Drugs.